The management of atrial fibrillation is an art, my dear. And I'll show how this art will play to your management planning of atrial fibrillation, my dear. It's not getting problem. But whenever, my dear, you start the procedure to irregular to regular, whenever, immediately that pushes this thrombus to come out and to go to the systemic circulation, causing this thromboembolism, my dear. The box said that the first line drug is nothing but the DOACs, my dear. And DOACs are nothing but DEAR. DEAR means D for dabigatran, E for edoxaban, and A for apixaban, and R for rivaroxaban. Similarly, whenever I say the cardioversion, so definitely the heparin is with that procedure, my dear. So atrial fibrillation management is an art, my dear. Art for adverse signs, radial rhythm, timing, my dear. Hello, my dear doctor. I'd like to discuss a very important hot topic for the exam, my dear. That is the atrial fibrillation. Atrial fibrillation management, my dear. I'm talking about the management because the 2021 NICE guidelines updated the management planning and everything all together. So knowing these facts is really important exam hot topic for your exam, my dear. So I'd like to discuss the atrial fibrillation management, my dear. As I said, my dear, listen very carefully. The management of atrial fibrillation is an art, my dear. And I'll show how this art will play to your management planning of atrial fibrillation, my dear. So let's do it, my dear. So let me show the atrial fibrillation, the ECG, my dear. Yes, we can see this is the atrial fibrillation. You can see the irregular, the fibrillatory waves, and the differences in the atrial flutter, which is the sawtooth appearances. Yes, my dear. So this is the atrial fibrillation, the fibrillatory waves that we can see, and there is an irregular. You can see this is irregular. Yes, my dear. You can see the RR irregular. So yes, my dear. So this is the atrial fibrillation, and this is the atrial flutter. This is not my intention. My intention to talk on the management of atrial fibrillation, and that is really art. I'll show you, my dear. So yes, my dear, just follow me onto the board. The management of atrial fibrillation is an art. So let me write down the atrial fibrillation management, my dear. I'm writing the SS box. The atrial fibrillation management, as I said, is an art. My dear, listen very carefully. Atrial fibrillation is nothing but tachyarrhythmias. What I said? The tachyarrhythmias, my dear. Whatever the arrhythmias, my dear, is it tachyarrhythmias or bradyarrhythmias, you need to do and assess the patients whether the patient is stable or unstable. Seeing any presence of any adverse signs, my dear, means, as I said, my dear, listen very carefully. Yes, as I say, it is an art. Let's see what art really affecting. So number one, the most important steps, A for, we are writing the adverse signs, my dear. What I say? The adverse signs. Means any adverse signs present or not. If the adverse signs are present, yes, my dear, what are the adverse signs? What are the adverse signs? I'm saying that A for adverse signs. What are the adverse signs? Adverse signs are, I'm saying, my dear, SSC, my dear. SSC means shock. S for shock. S for syncope. C for chest pain. And C for cardiac failure. So yes, my dear, this is very much important that you must know the SSC is a bundle pack of the shock, syncope, chest pain, cardiac failure. Say with me, SSC means the shock, syncope, chest pain, cardiac failure. Shock, syncope, chest pain, cardiac failure is a bundle PAC, my dear, of the adverse signs. So, my dear, listen very carefully. Whatever the arrhythmias, I always say that you need to see whether the adverse signs is present or not. If the adverse signs are present, the patient is considered to have the unstable patient, my dear. What I say? The unstable patient. In contrast, if it is absent, we call it the stable patient, my dear. So, unstable patient, the management should be shock, my dear. What shock? The DC shock. As I said, the patient having the shock, you should give the shock, my dear. And this shock is the DC shock, is a synchronized. We need to know the word, my dear, the synchronized DC shock. Yes, my dear. So what I say, the DC shock is the treatment of choice, my dear. So in the scenario, whenever you found, my dear, if the patient is having the atrial fibrillation, you need to look first the adverse signs. What I say, the adverse signs, my dear. Adverse signs means the SSC, my dear. Shock, syncope, chest pain, cardiac failure. And shock means the systolic BP less than 90 millimeter of mercury. Shock, my dear. Then you need to give the shock. If the patient having no shock, means no systolic BP less than 90, syncope means loss of consciousness, and chest pain means any evidence of the ischemic changes, even in the ECG, minor, there is the chest pain, and cardiac failure means any acute heart failure features. You shouldn't, and you should consider, yes, minor, the unstable patient, then you should give the DC shock, minor. If the features of the adverse signs are absent, you should consider this is the stable patient, my dear. Stable patients means they need to get down. The second important point, as I said, there R, my dear, art. R means that we need to think about rate versus rhythm, my dear. This is very important, the step that we are discussing. So means, my dear, whenever the patient is stable, in that case, we will think about the patient, the rate control or rhythm control. Means the unstable patient, if you give the shock, definitely you will make the patient to be stable. And these stable patients will get down to think about to rate control or rhythm control or both control. My dear, listen very carefully. Till the time, the date, the guidelines, we always try to rhythm control and the rate control, the both control, my dear. But nowadays that we have seen very few cases that we can do the rhythm control. That's why the strategy is changing, and they are saying the rate control strategy is more important. So yes, my dear, the preference of the rate control that we need to learn, and also the preference of the rhythm control that we need to learn. It is said that the rate control strategy is age and angina. This was the previous guideline, saying that the age and angina. So yes, my dear, we need to know an age and angina. Angina means the ischemic heart disease. Any forms of ischemic heart disease, you should prefer the rate control strategy. Yes, my dear. In contrast, the rhythm control strategy, yes, it is said that is the age is more than, yes, my dear, the 65, you can say 65 years. So here is the, yes, the rhythm control, the young patients. It said the symptomatic, young symptomatic. Then say that the lone, only atrial fibrillation, young symptomatic lone. Then alcohol, lone people will take the alcohol. Yes, and they will lead to the failure. So nowadays it's said that the young peoples and the alcohol, any precipitating or the reversible causes, in that case the rhythm control strategy should be applied, my dear. So I'm writing even then. So nowadays it said the young peoples and symptomatic and lone and alcohol. Yes. I'm writing and focusing the lone atrial fibrillation and alcohol. So you can say the young symptomatic lone alcohol failure, young symptomatic lone alcohol failure. These are rhythm control strategies should be, means the failure means the cardiac failure. But my dear, nowadays they say only the lone and only the alcohol, any precipitating factor. In that case, the rhythm control strategy should be applied. So my dear, listen very carefully. The rate control, how we do the rate control? We do the rate control, the box, my dear, the drugs are available. That is the bundle packs of BCD. B for beta blockers, write it down, my dear. C for calcium channel blockers, and D for digoxin. What I say? Digoxin, my dear. B for beta blockers, calcium channel blockers, and digoxin. In contrast, it is said that now beta blockers, yes, the calcium channel blockers, the rate limiting calcium channel blocker, especially the diltiazem, And one of the important things, they say that the beta blockers and calcium channel blockers is the first line treatment. Yes, they say that we can use the beta blocker or calcium channel blockers or digoxin. If it is not controlled, that we can add beta blocker plus calcium channel blockers altogether. And especially the calcium channel blockers, there is the beta blocker, especially this is diltiazem. This is diltiazem rather than anything else. So this is the important things you need to know so that you can be able to write your answers. Next is the rhythm control, my dear. Control of the rhythm, it does mean conversion of the arrhythmia to normal rhythm. It does mean the cardioversion, similar term, my dear. Means the rhythm control means the cardioversion. Rhythm control means the cardioversion. This cardioversion can be done, yes, my dear, this cardioversion can be done by drugs, means the pharmacological cardioversion, in two ways. What is, we can write down the two ways. One is electrical cardioversion and another is pharmacological cardioversion. Yes, my dear. Electrical cardioversion and the pharmacological cardioversion. Electrical cardioversion means the DC shock. And this DC shock is synchronized. Definitely synchronized DC shock. And pharmacological agents are available for the cardioversion is, I am saying, AF is the box, my dear. Means what I'm saying, AF means A for amiodarone and F for flecainide. My dear, listen very carefully. Among them, the most important or first line, if I'm saying the flecainide is the first line. I'm saying the first line drug, my dear, for the rhythm control. And also you need to learn the flecainide is contraindicated in structural heart disease. Just write down. Flecainide is contraindicated in structural heart disease. So if it is, the scenario says that the flecainide means the scenario says the atrial fibrillation with some of the structural heart disease. In that case, that you can't use the flecainide, my dear, you should use the amiodarone. So amiodarone is the next one, means amiodarone can be used with the structural heart disease. Amiodarone equal to structural heart disease. Yes, my dear. Amiodarone can be used the structural heart disease. So yes, as I said, the atrial fibrillation, so that you can remember, so that I can say a little bit, the drugs are available here. Option had the electrical or pharmacological cardioversion, but the drugs are here. You can see the A, B, C, D, E is not there, so F might. So there you can remember the drugs are used for the rate and rhythm control. The drugs might. So the rate control, the B, C, D, B for beta blocker, calcium channel blockers, and D for digoxin. And once again, on the other hand, that the rhythm control, the A for amiodarone and F for flecainide, but the F for flecainide is the first line, my dear. If the option is given, atrial fibrillation without anything else, the clean-cut atrial fibrillation, what is the most powerful agent, or what is the first line agent to control the sinus rhythm, or to maintain the sinus, to restore the sinus rhythm? So definitely the flecainide will be the answer. If the structural heart disease is there, atrial fibrillation, in that case, amiodarone will be the answer, my dear. So my dear, listen very carefully. This is very much important, and also the rate and rhythm control. Now, if you prefer to have the rate control, in that case, definitely that you should use this box, my dear. That is the BCD. That is the BCD, the beta blocker, calcium channel blocker, and digoxin. And as I said, that you can start with the single drug, the B for beta blocker, C for calcium, or digoxin, anyone. The first line is the first line. Yes. And if it is not controlled, then the second line, then you can add or combination, or you can add any other drug like the beta blocker and calcium channel blocker, and especially beta blocker and calcium. But this is the delta agent that you need to add, my dear. So this is one of the important things that you need to know. So my dear, listen very carefully now. As I said, the atrial fibrillation, management of atrial fibrillation is an art. So definitely A for adverse, R for rate and rhythm control. Now we decided to for the rhythm control. So you feel that a patient is having the irregular heartbeat. So now you decided to go for the rhythm control. So you need to hold for some time to think about, to T for think about, and T for timing, my dear. Time of the atrial fibrillation is important. Yes, my dear. What I say? The timing, my dear. What I say? The timing, my dear. What I say? The timing, my dear. So this is very important, that what I'm doing now, little bit discussion. For the purpose of the discussion, I'm just erasing them from here so that we can write down the things from here. Yes, my dear. I'm writing, so I'm also erasing the atrial fibrillation, means the amiodarone and flecainide from here. Yes, my dear. So T for timing. So if I'm writing the timing regarding the T for timing, my dear. Timing of the atrial fibrillation is really important. It does mean if the atrial fibrillation is less than 48 hours, that you do the cardioversion, my dear. You do the cardioversion. I'm saying the CV means the cardioversion, means the rhythm control. You can write down without anticoagulation, means anticoagulation. Or atrial fibrillation is more equal 48 hours. You do the cardioversion, but you should have the anticoagulation. So it's a box, my dear. I would love to write it down and say with me once again: atrial fibrillation less than 48 hours, cardioversion without anticoagulation; atrial fibrillation more than 48 hours, cardioversion with anticoagulation. Say with me, my dear, 3 times: atrial fibrillation less than 48 hours, cardioversion without anticoagulation; more than 48 hours, cardioversion with anticoagulation. What does it mean, my dear? My dear, listen very carefully. When the atria is febrile and atrial fibrillation age is more than 48 hours, the stasis of the blood in the atrium that leads to the left atrial thrombus, left atrial appendage thrombus, yes, my dear, means the thrombus formation needs the 48 hours. So whenever the atrial fibrillation is less than 48 hours, we think about very less likely, sometimes unlikely, to have the left atrial thrombus. So we can do the cardioversion. My dear, listen very carefully. If you just think about here, A left atrium is the febrile. A left atrium is febrile, is an irregular. So just feel it. It is less than 48 hours. It is less than 48 hours. So we think about, yes, we can do the cardio. But if it is more than 48 hours, so whenever the blood is coming inside, and the age is more than 48 hours, so it causes already having the clot that we can think about. Definitely some clot is there in the left atrium or maybe in the left atrial appendage, my dear, the hiding part. So this thrombus is very good inside the left atrium or maybe in the left atrial appendage. It's not getting problem. But whenever, my dear, you start the procedure to irregular to regular, immediately that pushes this thrombus to come out and to go to the systemic circulation, causing this thromboembolism, my dear. So that's why, my dear, listen very carefully. What I said, just feel it. A patient having the atrial fibrillation more than 48 hours. And this patient has got a thrombus inside the left atria or maybe left atrial appendage. It's fine. If you don't touch the heart will have this thrombus inside the left atrium or maybe in the left atrial appendage. Now, whenever you start the procedure to make the atrium to irregular to regular, then you push this thrombus to lodge into the left ventricle, goes to the systemic circulation, causing the stroke. So, my dear, that's why if the atrial fibrillation time is more than 48 hours, we are concerned that definitely something inside in the left atrium, means the left atrial thrombus should be there or maybe left atrial appendage thrombus should be there. In that case, we need to treat it fast, lysis the thrombus, means broken down the thrombus fast, and treat it fast, and then do the cardioversion, means the rhythm control or rhythm maintenance, my dear. So in that case, that's why I am saying this atrial fibrillation less than 48 hours, we can do the cardioversion without anticoagulation. But yes, atrial fibrillation more than 48 hours, we need to treat with the anticoagulation, my dear. One of the important box that I'd like to give here, yes, my dear, one of the important box, so that you shouldn't confuse. Write down, my dear, one of the box here. The atrial fibrillation less than 48 hours, definitely cardioversion. It is said that less than 48 hours, yes, my dear, in that case that you choose the electrical cardioversion. In contrast, if it is more than 48 hours, in that case, the pharmacological cardioversion is preferred. So another box that I have written. Another one, mind. Whenever I say the cardioversion, this is added with heparinization. Please don't confuse this heparinization with this anticoagulation treatment, my dear. Means, my name is Sumanto Kumar Saha. It does mean I have the two other names, Sumanto Kumar Saha. When I say the Sumanto, means the Kumar Saha is just added to my name, my dear. Similarly, whenever I say the cardioversion, so definitely the heparin is with that procedure, my dear. It's not a separate thing, not the separate anticoagulation that we are thinking. Now let's talk the atrial fibrillation less than 48 hours. You do the cardioversion without any anticoagulation treatment prior to that, minor. Otherwise, if it is more equal 48 hours, you need to do the anticoagulation. What does it mean? The main box of this more than 48 hours, yes, my dear, you need to write down this box. Atrial fibrillation, if it is more than 48 hours, yes, my dear, what you need to do, the way I'm writing, you need to do the first is the transesophageal echo. Yes, my dear. To see whether there is left atrial thrombus or left atrial appendage thrombus or not. If the left atrial appendage thrombus is absent, so yes, we can do the cardioversion immediately we don't need to treat it once again. If the left atrial thrombus is present, definitely we need to treat the patient fast by warfarin at least 3 weeks, my dear. Just write it down. After 3 weeks of treatment with the warfarin, to see the complete resolution that has been happened on the transesophageal echo. The way I am writing, my dear, shortly, that will be helpful. So yes, after 3 weeks of treatment with the warfarin, we'll see the complete resolution that had been done by the transesophageal echo. If the resolution that has been happened, yes, then we'll do the cardioversion, my dear. Then we'll do the cardioversion. Means this is the time for the cardioversion. After the cardioversion, it is said that after the cardioversion, we will treat the patient the warfarin at least the 4 weeks, my dear. And sometimes it is said that the warfarinization or anticoagulation treatment should be continued at least 4 weeks or the lifelong, my dear. The lifelong boxes are for whom? The high risk group, my dear. What I said? The high risk group. The high risk group are nothing but the mitral stenosis, dilated cardiomyopathy, and severe LV systolic dysfunction, my dear. What I say? Mitral stenosis means the rheumatic heart disease, dilated cardiomyopathy, and LV systolic function. Now the question is why? Severe LV systolic dysfunction, dilated cardiomyopathy, mitral stenosis leads to the left atrial enlargement. All are irreversible changes causing the blood to be stasis, high risk to develop the thrombus, high risk to develop the thromboembolism. That's why you need to treat this warfarin treatment, my dear, for the lifelong. I hope that you got it, my dear. This is one of the important of the box. So this is the flow chart that you need to maintain. Then after 48 hours, transesophageal echo that you need to do to see the LUT. If LUT or LAD is absent, you can do immediately. Cardioversion immediately. Immediately, my dear. In contrast, yes, if the present, then you need to treat it fast. Warfarin with the 3 weeks, resolution to see the transesophageal echo. If it is the complete resolution that had been happened, then do the cardioversion and then warfarinization for the 4 weeks or lifelong for the high risk group, my dear. So this is very important, my dear. And next talk, my dear, I'm just number 4. This is very much important. As I said, this is very much important. The atrial fibrillation management is an art, is an A for adverse signs, and then R for rate and rhythm, and T for timing. Yes, my dear, means the T for timing is an art. And definitely number 4 is very much important, whether you will give the prophylaxis with the anticoagulation or not. Means the atrial fibrillation is a risk of the stasis itself that leads to the thromboembolism. So that's why the prophylaxis is really needed. And this prophylaxis is based on definitely chart VAS scoring versus the bleeding risk, my dear, versus the bleeding risk, that is the orbit, my dear. Previously, the orbit was basically has blood scoring, but nowadays orbit scoring, that is one of the input that you need to know, my dear. So it is said that regarding the chart VAS scoring means that you will give the anticoagulation or not. Anticoagulation or not depends on the chart VAS scoring versus orbit scoring, my dear. So saying that the chart VAS scoring, it is said, my dear, this is important. If the 0, the answer is no anticoagulation. If the score is 2, you see the 2 and 2, this does mean that I'm saying the 2 means definitely anticoagulation. And if the score is 1, yes, my dear. So the question is, you can give or you cannot give, my dear. But in that case, the 1, you will see the female sacs usually 1. So female, 1 score you shouldn't give. So that's why they say that the male 1 equal to anticoagulation, but female equal to 1 equal to not anticoagulation. It does mean in case of male that you should give the anticoagulation if the score is 1, my dear. Forget them. Yes, my dear, 2 is anticoagulation. It is also said that the Chartworth score is 0. This is very important, the information. Now Chartworth score is 0. So definitely you shouldn't give the anticoagulation. In that case, it is said that you must do transthoracic echocardiography to see whether the mitral stenosis or not. If the mitral stenosis is there, definitely anticoagulation should be given. Like the way that I said here, the mitral stenosis, rheumatic heart disease, and the DCM and the LV systolic dysfunction. This is the flowchart, my dear. On the other hand, the orbit score, my dear, I'd like to tell a little bit the orbit score. So the O for, this is very much important, old age, my dear. Old age means more than 74. R for reduced hemoglobin. Reduced hemoglobin. B for bleeding risk. Any bleeding risk. I for impairment means renal impairment. And T for treatment with antiplatelet. Yes. So this is all about the orbit score. Till today, the formally it is not said that how the score will lead and how and what not, but little bit estimation is there. As I said, the 2, 3, 4, it does mean the 2, 3, and 4. Means the score, if it is 0 to 2, means 2, is the low, this is the medium, and this is the high risk. And the mortality is said that the 2, 4, and 8. So this is one of the box that you can write it down, but you don't need to get it by heart, only knowing the facts of the orbit scoring, my dear. So O for old age, R for reduced hemoglobin, B for bleeding risk, and I for impairment, and T for treatment with the antiplatelet. One of the Chartworth scoring, the anticoagulation, this is important, the anticoagulation R. This is another box, my dear, that you need to know. Yes, another box that you need to know, the anticoagulation, the chart, it is said that the box said that the first line drug is nothing but the DOACs, my dear. And DOACs are nothing but DR. DR means D for dabigatran, E for edoxaban, and A for apixaban, and R for rivaroxaban. Rivaroxaban. Yes. So this is the DR group of drugs, my dear, the DOACs. It is said that this is the first line drug, my dear. And nowadays is the second line drug is warfarin. Why? Because these DR and the DOACs don't need any monitoring of the treatment, my dear. So that's why this is the important box of the anticoagulation that you need to know, my dear. So these are the important informations that I have already shared. And one of the important talk, my dear, I'd like to give a smallest box here, very here, that will be helpful, my dear. So whenever the atrial fibrillation is a concern, so yes, my dear, warfarin means the anticoagulation must be given. It is said that this is the number 4, this is the number 4, yes, and I'm writing the number 5 here. This is called the post stroke prophylaxis. Another box, my dear. Post-stroke prophylaxis. It is said that if there is an atrial fibrillation with the stroke, definitely we need to give the warfarin, my dear. Or atrial fibrillation with the TIA, definitely we'll need to give the warfarin. Means anticoagulation, my dear. What I'm talking about. So it is said that the atrial fibrillation definitely warfarin, my dear, with the TIA. But warfarin that we can start the day one, my dear, immediately. In contrast, in case of stroke, in case of medium to large size of the infarctive stroke, in that case, we'll start the warfarin, but after 2 weeks, my dear. Means the warfarin should be started, it is said that day 10 to 14 days after the acute stroke, my dear. And in the bridging period that we can give the aspirin. So this is important, and these warfarin after 2 weeks. So this is one of the most important information that you need to know, my dear. So what I said, this is very much important, my dear. Yes, the post-stroke prophylaxis, the atrial fibrillation, stroke, TIA, warfarin should be given. Means the anticoagulation should be given. But in TIA, you can start now, today, immediately after the TIA. But in case of stroke, then you need to hold for few days, like the 14 days, 10 to 14 or 2 weeks, before starting the warfarin or anticoagulation. Now why? Because of the infarctive stroke, moderate to large size, there is a chance of hemorrhage if you start the warfarin immediately after the full-blown stroke, my dear. So that's why you need to wait for 2 weeks before starting the warfarin, my dear, in case of stroke. So the summary talk, the atrial fibrillation, TIA, stroke, warfarin will be given, anticoagulation must be given. Because the chart verse scoring is saying that, you see, the C for congestive heart failure, H for hypertension, A for age more than 75, 2, and D for diabetes, S for stroke. So stroke itself is a 2, my dear. And V for vascular disease, A for age, once again 64, means that up to 65 to 70, means the 65 years. And this sex for female is a 1, my dear. So this is the say that the A for age and S for stroke. Stroke people should give, you see, the 2 means the score is 2. Essentially means that the stroke people will get the 2. So definitely given the warfarin. So what I'm saying, the atrial fibrillation, whether the TIA or stroke, you should start the warfarin, my dear. But after 2 weeks, my dear, this is the message. So yes, my dear doctor, as I already discussed, this is a very important talk. What is this? This is the atrial fibrillation management is an art, my dear. It's a 5-star topic, my dear. Atrial fibrillation management is an art. Definitely is an art. Art means A for advercise, R for rate and rhythm, and T for timing, my dear. If I'm just erasing this smart, yes, my dear. So T for timing, yes, my dear. And then I just added for A for anticoagulation. And once again, the number 5 is a post-stroke prophylaxis. So once again, advercise, rate and rhythm, timing. Advercise, rate and rhythm, and timing. Art, my dear. Yes, the atrial fibrillation management is an art. So once again, A for advercise, present means the unstable, SSC, my dear, the presence unstable means the patient having the shock, then give the DC shock. If the patient is stable, then you can get down to treat and think about the rate and rhythm. And rate and rhythm strategy, as I say, the age and angina. But yes, most of the patients nowadays, we do the rate control strategy rather than rhythm. Rhythm is a very few cases. Only some cases that I say the low atrial fibrillation and some of the precipitating cause. For the rate control strategy, as I said, the important SS box here, the rate control strategy, BCD, beta blocker, calcium channel blocker, and digoxin is a treatment of choice. You can use separately any one of them. The second line is a combination of the treatment. And then rhythm control strategy, if you decide, there is nothing but the 2 varieties, the electrical cardioversion or pharmacological cardioversion. In that case, definitely, yes, the atrial fibrillation means the AF for A for amiodarone, F for flecainide, but the flecainide is the first line, flecainide is the first line, flecainide is the first line, amiodarone is the second line with structural disease, flecainide is the first line without structural heart disease. Yes, my dear. Next talk, whenever you decided for the rhythm control, then you need to think about the timing. Is less than 48 hours anticoagulation without And the cardioversion with anticoagulation, that is nothing but the preferred less than 48 hours do the electrical cardioversion, and if it is then pharmacological cardioversion. And cardioversion means the heparinization that should be added, my dear. And the strategy said that you should do the toe, then lat is negative, then you can do the immediately cardioversion. And then this is important, the 3W, and this is the 4 weeks, my dear, means the anticoagulation before and after. Or sometimes you need the long list with the lifelong, especially you need to remember the mitral stenosis is a single cause, my dear. And the anticoagulation, definitely the chart bus and orbit scoring, yes, my dear, and that you need to know. And last, the post-stroke, the atrial fibrillation means the anticoagulation must be added, my dear. So atrial fibrillation management is an art, my dear. Art for adverse signs, radiant rhythm, timing, my dear. I hope that you enjoyed. Thank you very much.